With a mind map on the principles of electrocardiography, um, let's try and brainstorm and remember everything that we know. Electrocardiography has to do with the recording of the heart's electrical activity as it propagates through the cardiac tissue. This is a non-invasive technique which provides a baseline representation of the electrical events that underlie cardiac function. So the purpose in clinical use is that it detects and diagnoses arrhythmias, myocardial infarction, or ischemia, conduction abnormalities, and electrolyte imbalances. It serves as a screening and monitoring tool in both the acute and chronic cardiac conditions. With a basic cardiac electrophysiology, remember the cardiac electrical activity. So the heart functions as an electrical system where specialized pacemaker cells, the autorhythmic cells, primarily in the SC node, generate impulses. The electrical impulse is spread via a conduction system that includes the sinoatrial node, atrioventricular node, bundle branches at the Purkinje fibers. The electrical dipole concept: each cardiac cycle generates a dipole um, during depolarization and repolarization, and the summation of these individual dipoles produce a net electrical vector, which is what the ECG records. So the ECG instrumentation and setup: the electrodes at the lead system. Electrodes, um, conductive pads attached to the skin, which detect the voltage differences generated by the heart. When it comes to the leads, there are specific configurations, the bipolar and unipolar, that record the heart's electrical activity from different spatial orientations. When it comes to amplification and filtering, the raw cardiac signals are small in the millivolts range and require amplification and filtering to remove noise and artifacts. The recording system: the ECG machine converts analog signals to continuous trace, displaying waves, intervals, and segments that reflect the underlying electrical activity. So the lead system, you have the standard 12 lead configuration with the limb need leads and the precordial leads too. So with the limb leads, we have the bipolar leads, which are three. They are arranged based on the Einthoven triangle, and this lead record the difference in potential between two limbs. And still on the limb nodes, we have the augmented unipolar leads, which are AVR, AVL, and AVF. So it actually records the electrical activity from a single limb relative to a composite reference point. The precordial or chest leads are V1 to V6. They are placed at strategic points of the chest, and they provide a transverse or a horizontal view of the heart. It helps assess the electrical activity of the anterior and lateral posterior aspects of the heart. With vector projection, the cardiac vector represents the net direction and the magnitude of depolarization, and each lead records the projection of this vector along its own axis, offering multiple perspectives of the same event. With the ECG waveforms and their interpretation, the P wave, it reflects the atrial depolarization. The key consideration has to do with the morphology, duration, amplitude, which helps assess the atrial um, enlargement to ectopic atrial rhythms. PR interval is defined as the time from the beginning of atrial depolarization, which is the P wave, to the onset of ventricular depolarization, is the QRS complex. This clinical significance, the normal has to do with um, 120 to 200 milliseconds, and the propagation may indicate AV nodal delay. Shortening can suggest pre-excitation syndromes. The QRS complex is defined as the representation of ventricular depolarization, and the duration is normally less than 120 millisecond, and the morphology provides clue to ventricular conduction, such as the bundle branch blocks or ventricular hypertrophy. ST segment is defined as the electric period following ventricular depolarization before repolarization begins. And clinical use of this segment is elevation of the ST segments or depressions in the ST segments, which are critical markers for myocardial ischemia infarction. The T wave reflects the ventricular repolarization, and the key aspects, the inversions or peaking of T waves may indicate electrolyte imbalance or ischemic changes. The QT interval spans from the beginning of the QRS complex to the end of the T wave, and representing the total time of ventricular depolarization and repolarization. The clinical relevance, prolonged QT can predispose to arrhythmias such as pulsates, depointes. Right, so the interval segments and their normal ranges. Remember, PR intervals are 120 to 200 milliseconds. QR is complex less than 120 milliseconds. QT interval, it varies with heart rates. It's corrected with a QT C that is typically 330, 350 to 450 milliseconds for men and slightly longer for women. The ST segment typically isoelectric deviates during pathologies, and its importance of measurements is that accurate interval measurements are crucial for diagnosing conduction delays, ischemia, and potential arrhythmogenic conditions. The technical considerations and artifacts. Common artifacts include motion artifacts, electrical interference, and baseline drifts. With the motion artifacts, the patient's movement can create noise. Electrical interference, external electromagnetic sources may affect recording. The baseline drift, it can occur due to breaking of poor electrode contact. The signal processing filters are used to reduce noise while preserving the integrity of the cardiac signal. And proper electrode placement and skin preparation are essential for high quality recording. Okay, so let's look at the clinical applications and interpretation. Arrhythmia detection, identification of abnormal rhythms like atrial fibrillation, flutter, premature beats, true irregular P wave and QRS complex patterns are all indicative of arrhythmia or helps in arrhythmia detection. ST segment deviations and abnormal Q waves are primary indicators for myocardial ischemia and infarction. For prolonged PR and QRS intervals, they may indicate blocks or conduction delays in conduction abnormalities. And variations in the T waves and QT interval can be indicative of disturbances such as hyperkalemia or hypocalcemia. Yeah, so that is in electrolyte imbalance. Right, so integration of these with clinical findings, ECG interpretation is always correlated with patient's history, physical examination, and other diagnostic tests for comprehensive diagnosis and management. So the summary and study tips, the core principles. ECG captures the heart's electrical activity through multiple leads that provide various spatial projections. The interpretation of the waves, intervals, and segments is key to understanding the normal physiology and pathological conditions. With using diagrams to understand the lead placements and vector orientations will really help. And then practicing measuring intervals and identifying the waveform abnormalities on sample ECG tracings will help. Integrating the clinical case studies to correlate the ECG findings with the patient presentations will also be very, very helpful.